And good afternoon, everyone. It's great to see you all here today. And we're really excited to be into week 5 of this short course on Introduction to Palliative Care in Humanitarian Refugee Camps in Kenya. Really exciting to have each of you here with us today. I know some will be listening to our recording afterwards, which is fine. We know that you are all very busy. So even taking an hour out of your day, we do appreciate it. Today we'll be talking about self-care, and I will take the chance now to introduce our speaker. If you are on the call and you've joined a little bit later, just introduce yourself in the chat with your name, where you're working, and what your role is within the organization, because we really love getting to know each and every one of you. So my name is Erin. I'm coordinating this Project ECHO course through APCA as well as PalChase, and we're excited to have Professor Julia Downing with us today. She leads the organization called ICPCN, which is the International Children's Palliative Care Network. And she's been working in palliative care for many, many years. I'm sure she'll share a bit, but she's a long-term supporter of palliative care in difficult and fragile settings. So we've asked her to speak today about self-care and how to just manage with the trauma and the really difficult situations where you all are working. So I'll pass it over to Julia, and after Julia's talk, we'll have some time of discussion, and then we'll do our case review at the end of the call for today. Thank you.
Thank you very much, and hopefully you can hear me and see my slides. So I'm really pleased to be joining you today. As Erin said, I'm the Chief Executive of the International Children's Palliative Care Network. I'm also a professor in palliative care, and I lived and worked in Uganda for over 20 years. For the first 10 years, I was full-time in Uganda, and now I'm back and forth, but I know Kenya well as well. So it's really great to be here with you all. And also, I work in pediatrics, but I also have worked in adult palliative care as well. So as well as specifically looking at children's palliative care, I've had a developmental role in terms of palliative care generally. And as Erin said, I've also had experience in working in humanitarian aid situations, fragile settings, and I know some of you work with MSF, and I've had contact with MSF for many different times over the years. So it's good to be with you today, and it's also good to be talking about self-care and how do we, as people working within fragile settings and within palliative care, how do we look after ourselves? And it always makes me laugh a little bit when I do this session, because I have to think about myself, and I'm not necessarily always very good at doing this. I have got better, and I do value the importance of looking after myself, and I've also seen the impact when I don't. So it's a really key topic for us to think about. And today, in the next 20 minutes, we're going to look at why is self-care important, some of the challenging clinical experiences, and how do we develop a self-care strategy for ourselves. And each one of us will have a different strategy for looking after ourselves. So I want you to think, and I'm not going to ask you to comment on this, but I want you to think for yourselves. What causes you distress in your job? What is it that you find really difficult? What is it that you find challenging? What is it that raises your stress levels? What is it that makes you get home and at the night or after your shift and burst into tears or struggle to sleep because it's replaying itself in your mind? And I'm sure working within fragile settings, but also having some work in palliative care, you will see many different things that cause you distress. And I like this quote because it's so true. The expectation that we can be immersed in suffering and loss daily and not touched by it is as unrealistic as expecting to be able to walk through water without getting wet. We are working in situations where there is suffering and loss. We see that on a day-to-day basis. We see that within the setting we're working. We see that within the healthcare setting. We see that within palliative care. And we will be impacted by that. To say that we're not is not realistic. And also, if we are not, then we have become so hardened to it that maybe we shouldn't be working in that area. I always say that the time that somebody's death who I'm caring for when I don't feel it, that is the time when I leave palliative care. Now, I don't mean that I'm crying my eyes out so that I'm completely stressed each time somebody dies, but each time somebody dies, that is a human being who is dying, and I'm going to feel that in some way. So just out of interest, the WHO have got a 5 wellbeing index. So let's just see how you're all doing. So over the last 2 weeks, think about, have you felt cheerful and in good spirits? All of the time, most of the time, more than half of the time, less than half of the time, some of the time, and at no time. Have you felt cheerful and in good spirits over the last 2 weeks? What about, have you felt calm and relaxed? Have you felt active and vigorous? Have you woke up feeling fresh and rested? Has your daily life been filled with things that interest you? So just think about these 5 statements and think about how you would score yourselves on this. And again, I'm not going to expect you to tell us how you're scoring, but I want you to think about that. Have you felt cheerful and in good spirits? Have you felt calm and relaxed? Have you felt active and vigorous? Have you woken up feeling fresh and rested? Has your daily life been filled with things that interest you? So this is just a 5-question wellbeing index from the World Health Organization. It's a questionnaire that we can look at ourselves. We get a total score between 0 and 100 by multiplying by 4. So the higher the scores, the better our well-being. 50 or below is indicative of low mood, not necessarily depression, but low mood. And our well-being is not so good. If we have a score of 28 or below, then we really need to be doing something about that. So this is a index that has been validated, and it can help us just to think about quite quickly how we're doing. So why do we need self-care? Well, I think that's evident. But as clinicians, we have an intense personal involvement with our patients and their families. We, particularly working in palliative care, we get to spend time with individuals. We get to ask them and talk to them about those difficult questions. We get to see some of the things and hear some of the things that they've been going through. And so we need to look after ourselves. And whilst these experiences can also help us to grow, it can also make us feel vulnerable. And ongoing personal grief, ongoing trauma, ongoing listening to the suffering of some of the people we care for can have a negative impact. But we need to keep ourselves healthy, because we need to be healthy. And I know several of you on the call have a mental health background, maybe psychologists or psychiatrists or counselors. You know, we all know the theory. We need to keep ourselves well if we're going to be effective. So why talk about self-care? Well, we've already explained that. And I think working in humanitarian settings, it's even more important. But what we do know is that pain and sadness is inevitable, but suffering might be optional. So how we deal with that pain and sadness that is inevitable in what we do is so important. There are many stressors in palliative care. People have reported that they don't feel they're doing a good job, the frequent exposure to suffering and death, some of the communication challenges, conflicts within the team, a lack of support and work overload. If we think about the sheer demand for palliative care, we know that there is so much, and that can be a stress for us. Some of the responses to that stress are burnout, and burnout is a progressive loss of idealism, energy and purpose experienced by people in the helping professions as a result of the conditions in which we're working at. And this burnout can result in physical and emotional exhaustion. It can cause that depersonalized approach towards patient care, and it can impact us feeling incompetent, feeling that we're not achieving, feeling that we're not doing a good job. And that is a circle, isn't it? We feel that we're not doing a good job because we're burnt out, but then we don't do a good job because we're burnt out. And so that can be so difficult. There's the feeling of moral distress. How do we act in a consistent manner with what we would like to do as an individual, but also what we would like to do, what we would expect to do as a nurse, a doctor, a counsellor, a psychiatrist, a psychologist, because of all that is going on. And we can experience compassion fatigue, not having the emotional energy needed to care for our patients, not having the emotional energy needed to care for ourselves and our loved ones, let alone for our patients. Now, there are many predisposing factors that make burnout and make this more challenging for us. We've talked about the work overload, a lack of control over our own work environment, spending a lot of time on things that are inconsistent with your career goals. I have a friend who says we need to be doing enough of the things that make our hearts sing, the things that we want to do. If the balance between that and other tasks such as administration, if the balance is skewed, then that has an impact on us. And work that interferes with home life, again, can be a predisposing factor. But also there are many personal characteristics. We are all individuals, we're all different people. It can be harder if we're early on in our career. It can be harder if we attribute success to chance instead of personal accomplishments. What about overcommitment? I'm learning to say no. I'm very good at saying yes, but I don't necessarily have the time for that. Are we able to admit that we make mistakes? Do we have a need for absolute certainty? Do we see things in black and white? Do we believe that actually compassion fatigue is just a part of our job and we just have to get on with it? There are many predisposing factors and each one of us is different. But there are also protective characteristics. If we are committed to what we do, if we have a passion for what we do, if we're committed to personal growth, if we are hardworking, but also able to draw that line between work and personal life, our caring abilities, our rationality, and our self-awareness. Are we self-aware as to when we need a break? I've learned now what I feel like when I need a break. I know if I need to stop and have a break, and hopefully I don't get there because I take care of myself. But if I do, and I feel those stresses and that tension coming on, I know that I need to take a break. So some self-care, 1, 2, and 3 for self-care. The first is on expert advice. Reflective practice and self-care should be something that is part of one's ongoing routine, similar to keeping up to date with attending conferences and reading journals. As well as learning more, we must learn about ourselves and how we care for ourselves. We need to think about emotional exhaustion, depersonalization, sense of low personal accomplishment. How do we avoid burnout? So we need to be undergoing reflective practice and looking after ourselves, trying to avoid burnout, and then trying to avoid the negative effects of burnout. There will be times when each one of us find it all very overwhelming, but we need to think about, when that happens, how do we avoid the negative impact of burnout? So what is the impact of burnout? Well, we know that burnout can cause us to make mistakes, medical errors, lower patient satisfaction. If we are tired and irritable, we're not able to give what we need to give to the patients. That can impact the way that they recover as well. We can then go on to do unprofessional conduct. I remember a time when I was exhausted and I was just desperate for my holiday, and I was fine. I was doing really well until about an hour before I went on holiday. And then it all became too much for me. So we need to, and that is when I'm liable to do something that I regret afterwards, or to say something, or to speak in a way that I regret. Avoiding work or specific work tasks which are difficult. When we're burnt out, those things which we find challenging, we leave to the end. We try and avoid. We try and avoid dealing with difficult emotions. And sometimes when we're burnt out, we've had enough. It means we leave. We leave the profession. We stop doing what we love doing and what we're called to be doing. So what causes you distress, but also what makes your job fulfilling? What is it that you do as an individual that makes your job fulfilling, but also what is it that we do in terms of individuals, in terms of looking after ourselves? So it's always good to think about, what is it that makes our jobs fulfilling? Why do we do the job that we do? We know that there are rewards of working in healthcare. We know that the feedback we get from families is so important to us. And often we get feedback from the families that they are satisfied with the care, that we have made a difference. And that is so important. Our relationships with patients and their families are key as well. And I can name quite a few relationships which have taught me so much. We know that we can make a difference on patients' quality of life, and we can reduce suffering. And that is so important to us. Working in palliative care does change our perception of life. It helps us to value our life. It allows us to reflect on our own mortality. It allows us to reflect on our purpose, what we believe in, our values. It helps increase our self-awareness. It helps us to be more able to cope with stress and suffering. And it also helps us to have greater appreciation for the joys in life. It is satisfying to do a good job caring for a patient. Whilst a child's death is difficult, I can also feel a sense of satisfaction that we have made that process as good or as positive as we could for both the child and for the family. And it's important that we don't feel that the death of a patient is a professional failure. We know one of the challenges to good palliative care is that often we are continuing to try and cure and cure and cure, even when that child or that adult can no longer be cured. The death of a patient isn't a failure, and that is so important to us in palliative care. But it's also really important, and I have to remember this, self-care is not selfish, it's essential. It's essential that we take time looking after ourselves. And if we do that, we can reduce anxiety, stress, frustration, anger, and we can increase our ability to concentrate, happiness, to be energetic. So self-care is so important. And these are some information and some guides, and I can share this guide with Erin, or she might already have it, from St. Jude's Children's Hospital. They talk about the importance of resilience, and we need to build up our resilience as we look after ourselves. As we become more resilient, it helps us to recover better, it helps us to do our job better. And we need to do that both internally and externally. So internally, taking that period of relaxation, taking that time out. Externally, maybe it is ensuring we have 3 days. Maybe it is ensuring that we go for a run or go for a walk. Whatever it might be, we need to build our resilience. Some examples that they give around self-care is, I like this one, stop. If you're in a situation at work that you're finding difficult, just momentarily stop, take a breath, observe what's happening and proceed. Even if you only take 30 seconds, it can make such a big difference. Likewise, work on our breathing. Again, even if we only take 4 breaths, 15 seconds, it can just calm us down. It can just enable us to relax and to come into a better place. Mindfulness. Think about what we see around us, what we can touch, what we hear, what we can smell, what we can taste. Again, just helping to bring us into the present moment and reduce that stress. Some of us might use meditation. Maybe we have a particular religion or spiritual belief, and we can use that. Maybe it's yoga. Maybe there's something that helps us to, again, to refocus and to meditate. Think about those things that we are thankful for. That can help make such a difference. And then I love this, reflective prompts. Sometimes before I go to sleep, I think, gosh, what made me smile today? What was something beautiful that I saw? What is the best thing that happened to me? Trying to think on the positive. So we will share this information with you, and I think you're going to have copies of these handouts, so you will have that there. If we're thinking about a self-care plan, and just as I close, we need to think about the physical, the emotional, the psychosocial, and the spiritual, just as we think about our patients in terms of the total pain, the total individual, physical, emotional, psychosocial, spiritual, cultural. We need to think about ourselves in that way, and we need to make sure that we plan something. So yesterday I went for a long cycle ride. That was physical. It was also emotional because I did it with my husband, and we were able to talk and spend time together. It was fun to do, and we had a nice meal. We cooked together afterwards, and I felt nourished by just being out in the open air. So looking at ourselves as a whole, thinking about, have we eaten properly? If not, make sure we eat. Have we had enough fluids? If not, make sure we drink more. Have we had enough sleep? Now, that's not always possible, but if we haven't, try and get more sleep. Have we exercised? Have we actually had some social interaction? And this one is so important because so much these days, for some of us, is done virtually. So thinking about how we look after ourselves. There is a high risk of burnout. There is a risk of compassion fatigue. We know that working in palliative care, working in fragile settings, and bring the two together, and it's even harder. But we can make sure that we look after ourselves. We can make sure that we are in a good place to provide the care that we need to provide. So I know we're going to have a case study in a minute, but I think we're going to have some discussion and question and answers. So I'll hand back over to Erin for the next stage.
Thanks, Julia. Just wondering what people's initial thoughts are on some of the things that Professor Julia had been sharing. Gabriel, do you have some insight into your team, the people that you support? Do you do some support of your colleagues as the mental health focal point?
Hi, Erin. Thank you.
Hey.
Thank you. Are you able to hear me?
Yeah.
Yep, we can hear you.
Good. Yeah. So in MSF, what we've done, we've tried to number one, put up mission to support not only the palliative and mental health aspect, but also all healthcare professionals. So what we've done, we liaise with the institutions that offer psychosocial support for what you call telecounseling support. Yeah? So what usually happens is that when someone needs support, one, the mental health team is there to give PFA, and then after that, we link them with the institution so that now they can get follow-up support. In case one, there's need for a one-on-one session, then now our supervisors and our coordinators are able to link them with a new institution that is going to give them that outside the field, of course. Yeah. But of course, we also have.
And that's for your staff? Sorry? That's for your staff, or is that for patients?
That's for the staff. Yes,
oh,
that's
great.
for the staff. That's for the staff. Yes. And we also have some few facilities for the staff for exercising. And also, in case one needs any PFA sessions, of course, the mental health department is there. Yeah. Thank you.
Because I think it's so important, isn't it, that we need to look after ourselves, but then we need to support our team and support those that we work with to look after themselves as well.
So during this time of discussion, maybe we can just share around, you guys can put in the chat, but what are some of the things that make you feel overwhelmed at work? And then we can take a few questions. The case study will just take about 15 minutes. So if you feel confident to share some things that make you feel stressed at work, you can put it into the chat. I can start. Actually, I just learned a new way to do something on Zoom. So what we do is we all type something into the chat and we don't push enter until everyone is ready. And what happens then is you don't get people waiting for other people to share, and then there'll be a cascade of this. So why don't you take a minute to think of one thing? It could be a sentence, it could be a word, something that's making you feel stressed this week at work. And then when I say go, I'll ask you to push the word enter. So just take a minute. I will also participate in this game, Zoom game, I guess.
Yep, I'm all ready to press enter.
We're ready? Okay. Take a minute to think. Sometimes even just writing down what makes you stressed takes the power out of the thing, because sometimes you don't want to say what it is that's making us overwhelmed. All right, I'm gonna, on 3, push enter, and we'll see what everyone else in the call is thinking and feeling. All right, 1, 2, 3. Great. So we've got a few communication ones. I guess that's reassuring. Organizational policies, yeah, for sure. Pressure from work, definitely, due to high number of patients, workload. Thank you so much, everyone, for sharing. And if you didn't get a chance, you can do it now to share what is making you feel a bit overwhelmed or stressed at work. Julia's list is too long.
It always is.
The worst part is when you have multiple to-do lists, you just go to the next list. Yeah. All right, Annalice is sharing. She said too many patients in need, but too few carers, for sure. When the resources are limited and we don't have people to rely on to support our patients, it can be really hard. High workload, patients declining, for sure. I think Professor Julia talked about that a lot. Sometimes it can feel really overwhelming when our patients are in the process of dying, and when they're decompensating, and you do feel the weight of that. Even though in this program we are teaching that there's ways for us to improve quality of life despite the trajectory of people's illness, it still is a reality. It can be really, really hard.
Yeah, and there's challenges, aren't there, when the perhaps patient and family members disagree as well.
Lack of commitment, burnout. Well, thank you for playing my Zoom game. Thank you, everyone. I'm going to pass it over now, and if you do have questions in particular about the lecture, you can put it in the chat. Professor Julia will be with us for the next 20 minutes still, I think, so she can kind of monitor that. But I wanted to introduce our team that's going to co-teach the case study today. They are both working in the refugee camp in Dadaab right now. The first one I want to introduce is Annalice. She's a registered nurse, senior registered nurse with IRC, who's been working for over 10 years in the camp. She is specialized in palliative care. Although she doesn't have a formal role within IRC, everyone knows her as the palliative care person to reach out to. So we will continue, of course, to advocate for you, Annalice, in that, but she has been a faculty member for the last 2 courses, and we're really excited that she's going to present the case today. And she's working alongside her colleague, Ali Khamis. He's a clinical officer who also has worked for many years in Dadaab. He has shifted recently over to a private clinic where he's leading an outpatient program. Ali, I'm not sure if there's inpatient at your clinic, is there?
Yeah, we have both inpatients and outpatients.
Okay, sorry. So he helps facilitate care for patients in an inpatient and outpatient private facility in Dadaab. And we're pretty excited to have them both here. So welcome, Annalice. I think you're starting and then you're going to pass it to Ali. Is that correct?
Yes, Erin, you can share the screen.
Okay, perfect.
As the Erin is sharing, I would like to welcome you, all the participants, and I'll request that as we go through the case, you reflect on what Dr. what the other presenter has
Julia, yeah, Professor Julia, no problem.
What Julia has talked about.
Are you able to see it, Annalice?
Yeah, I'm seeing, I hope everybody is seeing the screen. Case 1, we have baby Zoya, a 6-month-old who initially presented to your hospital with the progressive weakness. She is not able to sit and was having trouble swallowing. You suspect spinal macular atrophy, severe progressive disorder, which leads to respiratory failure. Life expectancy becomes low, that is less than 2 years. Then your team counsels the family about the disease and prognosis, and they take her home for home-based care, for home-based palliative care. Monthly visits by a nurse. She is happy and doing well despite her weakness. Next. So, 2 months later, one morning, Zoya was found dead by her parents, and it appears that she aspirated in her sleep. Her parents are totally distraught, and the home care team continues to provide support for them with visits for bereavement. The home care nurse and community health workers are equally devastated. Ali, please take over the questions.
Good afternoon, everyone. Here we have the questions. We have: what emotions may the team be experiencing? What are personal self-care strategies? What are team wellness strategies? Next.
Ali, we'll just let people have a little bit of time to think about the questions. And if anybody would like to share their thoughts, their initial thoughts, or put it in the chat.
I think we are this case one. This was the questions we had in the session today. I think this also reflects the presentations of Professor Julia was giving us.
Mm-hmm.
I think before we go to the next case, you can discuss and see these questions. If I repeat what emotions may the team be experiencing? The second question was what are personal self-care strategies? What are team wellness strategies?
Tim, you can either raise your hand and speak, or you can share in the online.
Julia, do you have any thoughts, or any of the other faculty, just as people are kind of thinking about this really challenging case? Does anybody want to share a little bit, Vilma?
I mean,
As I-
this
Yeah.
so this is a really sad case, isn't it? It's really difficult. And yeah, everybody's going to be distraught. The parents are, the health professionals supporting the parents. So there'll be sadness, anger. I think you've put it in the chat. Grief. There might also be some guilt around, oh, you know, we shouldn't have allowed her to aspirate in her sleep. You know, even if it's something that you can't stop, there's also still a feeling that you should have been able to do something about it. So a wide range of emotions.
Yeah, I also think in this case, the initial kind of thoughts where the child was diagnosed after 6 months with a very difficult disease, poor prognosis, but then they seem to have come up with a plan. They went home, they scheduled regular home visits, seemed like they had really tried to think of everything. And then yet her death was quite sudden. So I think the idea around preparing families with difficult diagnoses when they have patients that have serious health-related suffering, when they're not exactly sure how long their child is going to live, yet it's still very sudden. I think it is going to be something that this team will think about a lot, and they will need to even debrief. I think self-care sometimes is even us coming together as a team of healthcare workers and talking about what happened, because there might not be many other people that would understand the situation as a family or a neighbor. Our neighbors, they might not really understand this. So. That
will be really important, Erin, to come together as a team and to discuss it. And I think another thing that you said there is key, because you can prepare somebody that they know that their child is going to die, but when it happens in a way that they're not expecting it, it can be really traumatic. Even though in theory they are expecting it, it wasn't supposed to happen like that. But team discussing and meeting together as a team and discussing this is going to be really important.
And for that home care nurse, I'm also wondering if maybe it is a good idea to take even just a few days off, if that was someone that you had, you know, quite a connection with. It sounded like the team had been with her in the hospital, then it sounded like it was the same team that was doing the home visit. I think taking a day off after a patient dies, you know, with, of course, the permission of your supervisor, that could also be something that, you know, in certain circumstances may be needed. Some people have written in the chat, sometimes you could feel neglect from the caregiver. So yeah, maybe the healthcare team isn't really sure exactly what happened. Guilt, demotivation, and discouragement for sure. All right, Ali, why don't we go to the next one, or Annaliese? I'm not sure who's going to present this one.
I think the next case, Annaliese will continue.
Perfect.
Okay, let's continue. Case 2, we have a 4-month-old baby presents to your hospital with a enlarging head for 1 month and lower back pain lesion since birth. Diagnosis of myelomeningocele and hydrocephalus. Then there was also rapid malaria test, which tested positive, respiratory distress and fever. The child is saturating at 54% of oxygen, that is at room temperature, room air, and then 93% on oxygen, 2.5 liters per minute. Then they started the child on IV antibiotics and malaria treatment, exploring possible transfer for shanty and neurosurgery. The picture, good picture of how meningocele presents. You can see it is attached to the spinal cord, which means there is possibility of infection to the meninges, and then the child is not able to sit well or to other functions. Next, Erin. Case 2, we summarize it as the child is 4-month-old with the hydrocephalus and acute illness, malaria, pneumonia, possible meningitis because of the myelomeningocele. Then patient is in a rural area. You can imagine where we are in Agadera. This patient is there, far from any possible hospital which could do a ventricular perinatal shunt. And then
Are you okay, Annaliese?
and maybe it is not in position to acquire at that time. Next, Erin. It is left for the team to discuss with their advisors via telemedicine, and it is agreed that the shanty is not appropriate in the setting due to lack of available expertise to follow up, high likelihood of that shanty to block in the short or to medium time. Care at a neurosurgical hospital will not be free. Of course, the charges are very high, expensive for local people with the low living standards. Then previous agreement with one of this hospital, but this had been discontinued because of very poor outcomes for the children there and the huge risk in international transfer. High likelihood of death during or around the time of transfer, and this could be a very traumatic experience for the family and even the healthcare providers. Next. Recommendation was for palliative care. Ventricular tracts can relieve intracranial pressure, but despite symptoms in the very short time. The relief will only be for a very short time, and then again, accumulation of fluids will be seen again. And then, but fluid always accumulate, and it created an easy route for further infection. Prolonged the patient's life, but did not change any or improve their outcome. So you can imagine this is how you can get burnout and stress, and then you will forget about yourself because you are thinking of discharge. Then after the treatment, plan of palliative care was discussed with the family, who accepted the plan and wanted to stay in your hospital for care. The baby recovers from his pneumonia and malaria and stays on the ward with the comfort focused care plan. He rapidly deteriorates 3 weeks later and dies peacefully on the ward. Several of the nurses become very attached to the baby and find it very hard to cope with his death. One of the pediatric nurses approaches the pediatrician later that week, asking why he wasn't resuscitated. The pediatrician organizes a team debriefing session. Next.
Next is our also case 2. The special questions that you have today also. In this case, we have some questions out there. What are some of the features of this case that could impact the nurses and the other team members' experience of moral distress in this case? What can the team do to support each other? What will you do if you are involved in this case to create a personal self-care plan? So let us now discuss how we can about this case 2 self-care plan. Erin.
Yes, I think in this case, if people also wanted to share, I think this example is probably quite common to the issues that you face, whether it's a child or not. But what are some of the things that cause us to have moral distress when we can't offer the care that we think is really needed for our patient? What part of this particular story do you think caused this team the distress? You're welcome to unmute if you want. Gabriel, do you have any thoughts on this? I know that you probably support a lot of your colleagues.
I think I like what has been presented on the case. I'm not so much into the pediatric side, but I know what we do in MSF. We do what we call what do you call this? It's more of a debrief on cases whereby mortality has occurred. So what usually happens is that the team sit down, they look at the case from admission of the patient, they look at the symptoms, the management plan, and then also on what transpired on the day the patient died. So in one of the times I've attended these sessions for one of the cases we've had in maternity, I've seen some of the my colleagues who usually are in denial, some who always have cases of guilt, self-guilt. At the end of this session, they usually accept the outcome of what has happened. And also we should always see a bit of encouragement after the session. It is very important, especially for the person taking lead in these sessions, to ensure that the staff understand that they did what they could. One of our MSF's approach is that we usually say we'll do everything we can, even if it is holding a patient's hand on their last meal. So this has really helped us, and that is what we always repeat. Even if you hold a patient's hand and that is the only thing you can give to this patient, that is enough. You've done what you could. Yes.
Thank you, Gabriel. That's a really very powerful statement, and I think it definitely goes to the idea of improving people's quality of life, and really thinking about their life and what they've done. And I think although the nurse that shared, wanting to know why we didn't resuscitate the baby, you could tell that they were very compassionate towards the child. They knew that the child wasn't going to live long, yet they still were challenged to develop a therapeutic relationship with the child. The idea that the nurse was feeling sad that the child dies, I think means that that she was very authentic in the type of relationship she had with the patient and the family. Doris, do you have any comments? Doris, you're calling in from Ghana. You're one of our faculty members as well. Do you have any thoughts on this case? Are you there, Doris? Maybe she just stepped away. Yes, Saeed, would you like to go ahead?
Yes, good afternoon, Erin and the teams.
Yeah.
It seems that this case sometimes is hard to digest, in that from the beginning, that the patient has these such problems that this case cannot be done, and the caretakers and others by informed. But the question that lingers in one's mind, especially the caretakers and others, especially if, for instance, an organization or agency has the capacity to could have done something for this patient, for this case, even if it means international transfer, they couldn't have waited all those long to see that this patient is suffering, when at least they know they could do something, because the essence of humanitarian is to save life. So the question that lingers in one's mind, and especially the staffs who are feel distress attached to the patient, is that always, why are we wait this long to wait until this patient dies, when we know there are other venues, even if it means international, this patient could have been often to see a sense of guilt.
Yeah. I think, Saeed, sorry, it's cutting in and out a little
Whereby
bit.
you continue asking yourself.
Sorry, Saeed, I think it was cutting in. Did you hear it, Annalice?
I didn't hear anything
at the end. I think that's Saeed, you bring up a really, really good point. Because at the very beginning of the discussion about this person, it was decided that the baby wasn't going to be able to get the care that would help the most. And I think in our situation, I think we can desire that people are able to access curative treatment, are able to leave the camp and get the surgery they need or be seen by the specialist. And I think that's probably, like you're saying, where the emotions of guilt come from. What we are wanting to support you all in is the reality that many, many of your patients are not able to. So what do you do in the midst of those situations? What how do you counsel the family and support them, knowing that it's not really fair, that the patient isn't able to leave the country, they're not able to get the treatment they need? How do we support people in these situations? I think it's definitely an ethical dilemma that we face as healthcare providers, and especially you at the front line of the humanitarian response. You want to do everything you can. And I think through this course, Annalice and Ali obviously can attest to this, that we are trying to support you and give you some skills where you do feel like there are things you can do despite the many, many barriers that you face and families and patients face. Annalice, do you have any thoughts on that? I'm sure you've had many cases like this also in your practice. How you manage these kinds of things.
Erin, we have a lot of such cases. Some some are managed to be referred to places like Nairobi, Kijabe, but at the end they come back here, and then the resources which are available here are taking care of shanty, and every time they are blocking arrangement for referral again back to the hospital. It is stressing both on the patient, the family, the organization, and it really hurts when you see a child die because they failed maybe to refer in time, or the relatives or the parents declined to come back again because they are tired of going and coming. It becomes so frustrating and hurting to see children die. Some have gone severally, they cry, we have gone 5 times, we have gone 10 times, and they come back with the same issue. I don't know what will happen. I was really crying if they can bring these services close to the beneficiaries. Instead of this referral back and forth, it becomes a problem. Patients accuse you, and yet there is nothing on your hands. Yeah.
I think we'll probably, sorry, we're over a little bit of time. We'll probably begin to wrap up, but I think these are the kinds of discussions I really hope we can have as a group. And I do really hope that you see each other, although you might be working with different organizations, that you would see each other as colleagues, and now even beginning to think about these really difficult situations maybe a little bit differently. I think access to the right care at the right time for our patients is something we probably will never stop advocating for. Annalice, I totally agree with you. What we are hoping in, even just thinking about this case where, the child is innocent, the child has done nothing, and yet still hasn't had a chance to live a long life. Because of the diagnosis, because of the place where the child was born, so many injustices came up in this case. And I think that although we try to think beyond the camp as a solution to the issues, I think one thing we want to challenge you as faculty is to begin to think of what we can do in the current situations where we are. What can we do to support families during this time? And although, yes, one of the pediatric nurses was really in almost like a moral dilemma about what happened with this child, you could tell they didn't disown the child. They continued to try to give care, and even at one point it said that the child died peacefully. So that probably means they asked the family what the family wanted. Maybe there was extra visitors at the child's bedside. Maybe they were able to take some photos together before the child died. The idea that we can offer a peaceful end to somebody's life is something that we can do, and we can do that in Dadaab, we can do that in Nairobi, we can do that in London. Yes, of course, the fairness and equality isn't there because of the situation that we face with our patients in Dadaab in particular. But we are challenging each of you to begin to think a little bit differently. Never change your attitude of always wanting what's best for your patients, but knowing now a few more skills in palliative care. What are some things that you can incorporate into your work? And it's not easy. You know, our calls are only 1 hour a week. But we, again, like I say, each week we are here to support you in your work. And with these really challenging cases, maybe people won't really understand that actually she did have a peaceful death. But we hope that there are ways that we can help empower you to allow those kinds of situations also to happen for other people. Ali, do you want to have a closing thought on just the end of this case, and then we'll wrap up for today?
Yeah, I don't have other much things to say, but I will comment on that's also like you give an example of the self-care that we support through psychological support, emotional support, spiritual support, and the briefing support for the patients who are close to their loved ones. So let us make promote palliative care through quality of life. Thank you.
Erin, I wanted to share something with the participants and maybe all of us. There is a colleague who shared for us some document on self-care. And then there was a section that said that the ABC of self-care.
Yeah.
Where A stands for awareness, and the B stands for balance, and the C stands for connection. That wherever you are, you should be aware of yourself, your surrounding, your work, and then you should balance between work and home life and yourself. But always think of yourself first because you cannot give what you don't have. You have to give the care that you have cared for yourself. So it is good when we go out there, when you are serving people, we should know that we have to give what we have given to ourselves. You can't give, the way Julia said that self-care is not selfish. You should give what you have and what you can afford. Don't give what you don't have. Then you have to connect to people, connect to your family, connect. For us, we work very far from our homes. We stay for long in the field. We call field our home because when you are going home, you are only visiting for a few days and you are back. So when you are in the field, we should connect to others. Some people don't like connecting, maybe to go and sit in a group and talk, but you can listen to music, you can call somebody and talk. That's also connection. Thank you.
Thank you. Thank you, Annalice. Thank you so much. And I know that you and Ali are very committed to growing palliative care in Dadaab for sure. And maybe one thing that we as a group can do is, regularly meet even once this course is over and talk about, some of these cases that are difficult. And it could be almost a self-care in and of itself to stay connected in this group. All right, next week we have a public holiday here in Kenya, so we won't be meeting. Next week is June the 1st. It's Madaraka Day, so please somehow celebrate wherever you are. My kids will be home from school, so I'm sure we'll be doing something fun. And we will get together again on June 8th. We have 2 more classes for this course, and I'm really excited. We are going to be rolling out a final quiz or test, kind of like a knowledge test And we'll be sharing that in the last 2 weeks. So you can begin filling that out just to see what some of the information you've been gathering over the last few weeks is. So thank you so much. And we'll see you in 2 weeks. Bye, everyone.